Yeah, and I can see your screen. Absolutely. Thank you
All
so
right,
much.
awesome. Okay, so yeah, of course. So thank you for having me. My name is Mike Kim. I am an assistant professor of anesthesiology here at Keck School of Medicine at USC. I'm also the medical director of the perioperative arena for the entire hospital system, and then also the medical director of the Value Improvement Office. So I oversee a lot of the clinical practice from the minute the patient steps into the hospital till they're discharged. So we play a small role in all of that. This is some older news here. We've gotten an honor roll. I think now urology is, I think, number 8 in the country.
Yeah.
So this is our hospital here: 3 hospital beds, 619 beds, 90 clinics, 5,000 employees, 800 faculty, 500 residents. And if you look at the date here for an academic institution, we're fairly young, right? I think the hospital's been around for a while, but the actual academic affiliation for the hospital has been about 12 years, right, since 2009. One of the things that I've really tried to understand about patients and their journey here is just how difficult it is for patients' families and for the patient overall when they're about to get their surgery, right? To us, it's pretty simple, at least from the anesthesia side, right? I put somebody to sleep, um, you do your surgery, I wake them up, and then usually the day goes on. Um, but for the family member and the family, they deal with a lot, and usually it's cancer. So what we really wanted to do here with enhanced recovery wasn't it, I mean, the main point of it, the end goal was to get patients in and out of the hospital quicker, but it was really to give them a journey that they understood and felt familiar with prior to coming to the hospital. So if we look at the way here that we have it, we have the referral from primary care. They get the preoperative portion here. So if you look at the red portion, this is all before they get to the hospital. The blue is when they get into the hospital and they get their operation, and the green is right after the operation, what happens. So there's if we look at the healthcare continuum as a whole, there are so many players and so many people who touch this patient at any given point, and really there's a lot of factors that could drive the way that patient care is done. So we wanted to standardize that. So if you look at the beginning here, we wanted to optimize the hemoglobin. Preoperative management here is giving them their carbohydrate drink, maximizing the patient's hydration, avoidance of bowel preparations. And then on the day of admission, we want to make sure that they're getting their carbohydrate loaded drink. In the intra-op, we've created a protocol, and I think we'll get into it here, but I think Andre's definitely seen the success of it, right? We have previously never done blocks. We were doing blocks now, and we have a robust anesthesia block practice in combination with the urology team. We avoid crystal oil overload, and for some patients, if we need to, we do epidural management. And then on the postoperative side, we're doing both routine use of water wound drains, no routine use of gastric tubes, and a lot of the therapy that's happening across this is happening within the postoperative period fairly shortly. So, and then the other component of this is also discharge on plan day and when criteria met. So, one of the things that we've done here, and one of the issues that we've heard when we were doing this in the very beginning was just constant communication that was coming from nursing about some of the education that they were delivering for the first time to patients. And one of them was, for at least for prostates, one of the first things that they were discussing with patients, or what they felt like patients were discussing for the first time, was Foley care. So we went back to the clinics and we said, hey, look, I think we need to provide some proper education about Foley care before patients land into the hospital. So that's something that we've resolved. And for the past 3 years, as this program has been growing, we haven't heard anything about that. So they understood that we were listening to them. This is just kind of our journey here at KMC. So patient decides they're going to have surgery. These are all educational pamphlets that they receive. They come in multiple languages now. So English, Spanish, I think our top 5 languages that they speak here are English, Spanish, Armenian, Korean, and Chinese. So all these pamphlets are translated into those languages. At the pre-op clinic, they get a carbohydrate loading drink. There's a plan that we put together that's embedded into a postoperative order set, and then we give patients a checklist. This is what you're responsible for after you come out of the operating room and when you land in your postoperative bed. And then again here, clear discharge goals, right? And then back return to health. We've had a few colleagues that have been on, I guess that age comes when you're, 50, 60 years old, where they've had this surgery, and they have, they'll be the first customers to tell you that they did not use any narcotics post-operatively, right? And the recovery was smooth. Um, this is not to show you that you have to have this type of collaboration or have to have these resources to make this work, but really, what we've been able to do and is to combine the forces of both the anesthesia department and the physician stakeholders, alongside with a portion of what we call the value improvement office, which is administrative help, to kind of give us an idea of what they can support, so that all system, I guess, all system goals or KPIs, or I don't know what they call them down in Brazil, but all system goals are met together, right? So that we're all speaking the same language, right? Why do we want patients to get in and out of the hospital as soon as possible? It's for us, it's because of patient recovery. For hospitals, it's because they could see more patients and we can bring more patients in. But those two things are they play in the same realm. So I think once we're able to bridge this gap in communication, things flowed a lot smoother. So we also have, if you look at here on this medical director side with the clinical nurse specialist, we really relied on this outpatient side here. This outside group of inpatient clinical nurses, as well as multidisciplinary teams. Here, for example, if we don't have the PA heavily involved with the post-operative care, we'll never see success in our program. And that's because the majority of the care that's being done post-operatively, from discharges to order sets, are done by PAs, residents, and fellows. And actually, it's probably done mostly by the PA. The PA kind of normalizes it all. So I think we've been able to capitalize on that relationship, and that's why this program has been so successful over the years. See, so if you really take a look at how many people are in the healthcare continuum of just this one patient for 24 hours, this is the group of people, right? So for us, at any given time, these are all the people that have access to the patient and can potentially change the trajectory of how your patient ends up afterwards. And so I think what we've done is we've tried to standardize this so that we can have this group of clinicians all be on the same page. So, some of the barriers that we've learned over time is everyone is trying to improve the patient journey. And oftentimes they just don't have the opportunity to collaborate. So we were that central piece in the middle here that allowed to bridge all these gaps in healthcare continuum, in the healthcare continuum for the patient. So, we gave them a platform, and we ensured that all the patients were heard. And at this point, this is when all the protocols started to get put into place. At Keck, and I'm assuming this happens in Brazil, but we have a robust patient experience, I guess, learning about what it's like to be a patient, especially one that's having cancer surgery. So this is just an illustration to show you kind of what the patient goes through in terms of their feelings as they're mapping their journey out through the hospital, right? From the time they get their diagnosis to surgical confirmation, feeling back down again, to the point where they're feeling a little bit better after the surgery, and then back home here. So we deal with a lot of this, and this is something that I think we don't always take into perspective, why a person or a patient responds the way they do, why the family members might respond the way they do, is that during this entire patient journey, there's a lot of ups and downs in the way that the patient is feeling. And sometimes they don't know how to voice it, right? So that's our job as clinicians to take that into perspective as we give them something that is formalized and something that has a routine pattern. So this is what we do. We come here to really learn about what this patient is going through at any given period of time. So why do we do this? We've learned that to get out of these lulls here, out of these low points, we want to educate repeatedly, reassure them of how they're feeling, but also re-educate them again, and then also improve some of the processes for us especially to smooth this process, we'd like to have them above here the entire time as they're going through the journey. And when they do have their surgery to peak up, and as they go home to peak up even higher. So this is a responsibility for us as clinicians to be able to understand this, because this is another, I believe this is a component of medicine that we don't learn in medical school, and we definitely don't learn in residency. And then all of a sudden, we're supposed to figure this out as attendings or attending surgeons. And at that point in time in your career, there's so many other factors that come into play. So this is a really difficult thing to embrace. But I think if you have a hospital that's willing to, that understands the clinician is the major customer for them, that we can solve some of these problems together. So this is, for us, this is just co-designing some patient education. If you see here, we can send these to you if you want to put this in Portuguese, right? So we could send these to you so that you can make your own copies. But here is just, what do you need to do before surgery? This is what happens during your care here. And really, the goal is for us to get you well faster, right? So this is also our preoperative checklist here with all of the asks that happen prior to this. This is our team. There's a small 4 of us. We let everybody know that they're on the protocol. They have a sticker on their book. They have a booklet. They've got a safety kind of KPI on every single floor for nursing parameters that we're meeting. So there is an ERAS section on every nursing floor. And we celebrate with food. That's we spend a lot of money on food to be sure that we share with nursing and their clinical staff that they're doing a great job, and the system, the patients, and everyone appreciate that. And for us, it's really more, once again, I mean, the food is a big play to it, but it's really about re-educating staffing as well. And then for us to really develop that relationship so that we know that when questions need to come from the nursing back up to physicians or physicians back down, that they know that there's a safe place for them to make that type of commentary. So just to give you an idea of what we do for prostates, on the day of surgery, we give them 300 milligrams of gabapentin, Tylenol 1 gram PO, and then 200 milligram for prostate cases. No bowel prep. This happens to be right preoperatively. On the day of surgery, this is the mix. I think if you don't have this medication, you can actually use 40 cc's. You can actually just use 40 cc's of Marcaine mixed with 20 cc's of normal saline and inject it into your port site. So I know that not everyone is granted the privilege of using this medication, but if anything at all, you do still want to be able to inject all of your port sites with some local anesthetic that will definitely help you with that nerve pain, just as you're coming out of the operating room, probably the most highest acute pain period. And then you usually can be able to numb that entire site. So what Andre can probably give you a better explanation of this, but what we do is we put the needle into the port site, and you can actually see the tenting of the fascia. And usually once you see the tenting of that fascia, you can inject. What we have is 5 port sites, so 12 cc's per port site. And you can see some pretty significant tenting there, knowing that you're in that fascial plane. And it does a great job. Intraoperatively, we give the expiral injections prior to port sites of 60 cc's of a volume of anesthetic. And then we don't give any opiate analgesics intraoperatively. It's very, very rare. And you know that your injections are working because of the minimal usage of narcotics throughout the case, as well as the minimal fluctuations in hemodynamics. Something we do a little bit differently for nephrectomies, and Andre, I don't know if you've heard, but we've been waiting for about a year for this paper to get accepted, and it finally did as of last week. So in the nephrectomies, on the side of the nephrectomy where the larger incision is happening outside of the robotic side, 10 cc's of Exparel, normal saline, Marcaine. Anesthesia does a deep QL block. I think if you're not familiar with that particular block, a tap block will work on that side. And then we continue to have port site injections from the surgeons. So total volume of anesthetic here is going to be 60 cc's, 10 cc's of Exparel, as well 10 cc's of normal saline, and then 10 cc's of 0.5% Marcaine. Postoperatively, what do we do? This is where the magic happens, right? So ambulation and diet immediately 2 hours after surgery. Lovenox, which is bridge, for 28 days. We prescribe tramadol, gabapentin, Tylenol on a normal basis, Colace, Celebrex for 14 days as well. And then this is the antibiotic that we're using over time. One kind of peripheral anecdote is that we've been actually DCing Foleys faster before. I have no idea why that's the case. It just happens to be part of some new standardization. And I think that's what happens when you start standardizing some form of protocol, that there's some other portions of the clinical care that just happen to come into place. And that's just I guess it's just a portion of what happens when you start standardizing care. So this happened. This is just to give you some of our latest data. This got accepted. Here's our p-value here. If you look at the perioperative length of stay, all less than 0.01. We've dropped our narcotic use by over 66%. Length of stay drop is greater than less than 1 day, and we dropped our length of stay also by about 20%. So I did not add the nephrectomy data. Sorry about that. I apologize. But we've gotten this one. If you see it, it's got accepted into the Journal of Robotic Surgery. This is from our fellow from 2 years ago, Ashrafi, with resident Wesley Yip. I think now he's in New York doing his fellowship. And then here for robotic surgery as well, for nephrectomies and enhanced recovery after surgery robotic protocol for robotic assisted laparoscopic nephrectomies utilizing the QL block. We've gotten this just accepted as well in the Journal of Robotic Surgery. So they sang with praise. We only had one revision for both of these papers, mostly clarification of how we collected data. And that's where we are. So I think we're doing a good job. Dr. Berger, I know that you do a lot of work out here, and we thank you for the partnership. And conversations like this, as well as conversations that we have across the system, are the reason why we've been able to have the success that we're currently having. And hopefully, if there's anything that we can help you with on this side, especially in Brazil when it comes to even the educational platform, please let us know. We'd love to be able to help out.
Thank you so much, Mike. Brilliant as always, and remarkable work that you're doing there. You really are making a huge difference in the entire system, and we really appreciate that.